What are our therapeutical options for treating patients with laryngeal papillomatosis? Well, the bad news is that there's not one thing that we can do and then the papilloma are gone. What we have is papilloma as a, let's say, mostly benign lesion that is very much recurring, which means coming back. And they grow and grow. They can grow rapidly or not so rapidly. Our technique for treating papilloma is that we try to debulk, which means we take away, we reduce the mass of the papilloma. Why do we do that? We think that when we reduce the mass of the papilloma, which always grow superficial on the surface of the mucosa, on the lining in the vocal fold or in the larynx, and if they grow on the top, then we just have to shave it off or take it off, laser it off, and when we debulk it, mass reduce it, then we hope that the immune system of our patients can do the job of the residual viral loading that stays there. Now, a frequent question is, Doctor, why don't you take away even the upper lining and just shave it away that everything is away, then they won't come back? Well, this is not true. Papilloma virus is everywhere in the body. We don't know why they grow on the vocal fold or at, let's say, some points, and why don't they grow on other points. So just taking radically everything away would destroy too much, would lead to scarring, and scars is almost always coming in with hoarseness, and then irreversible probably, or long-lasting hoarseness. So the idea is mass reduction, keep the vibratory properties of the vocal folds, and then look for other components that can reduce the papilloma. We will talk about that in a second. Now, how can we take off the papilloma of the vocal folds? Well, the answer is, since, let's say, a couple of decades, we use the CO2 laser in general anesthesia, which means we burn the papilloma, we peel them off until we reach the level of the mucosal lining, and then let the immune system do the rest. If that doesn't work, then they will regrow and the patient has to come back and be put asleep in general anesthesia for another surgery. It can happen that some patients are operated on a dozen times or 20 or 30, and I had a patient who was done 150 times. That's a lot. So we need some concepts to think about how can we reduce the recurrence rate. Now, there are several options also that can help. Let's stay first with the mass reduction. Do we always have to have that in general anesthesia? And the answer is no. We can do it office-based. Now, how do we do that office-based? We can use small little glass fibers. And here's one of those glass fibers. As you can see, this is a small little glass fiber. I don't know if you can really see that. It's very thin. And this glass fiber is very flexible. As you can see, it does not break. And we can pass this glass fiber, I will show you the tip here, into a flexible endoscope, which has a working channel, and then office-based in the awake, unsedated patient, pain-free, transnasal, flexible endoscopy. We can go, like we did for the diagnostics, with a channeled endoscope. We pass this along all the way into the larynx and then feed this little glass fiber into the endoscope until it reaches the vocal folds, and then we can laser in the office. Vocal folds don't have nerve fibers, which means if you laser vocal folds, that doesn't hurt. What patients do, they sense maybe the smell of a lasering procedure. But the real take-home message is that you don't need to have general anesthesia all the time. You can do office-based outpatient lasering within 10 minutes. We can also inject something that we will talk about a little bit later. So, office-based, awake patient treatment is possible. What kind of lasers can we use? Well, the CO2 laser is not our preferred option for this kind of procedure, but there are other so-called photoangelitic lasers that are on the market. It started off with a PDL laser 2 decades ago or even longer, and then there was the KTP laser, and now we have the blue laser, and the blue laser is a portable little laser that can do the job when we do office-based procedures. So our concept is, when we have a patient who has big masses of, let's say, papilloma in the larynx, then we do the first surgery in general anesthesia, take a biopsy, look for the subtyping, and then ask our patient to come back and try to do as many procedures in the follow-up office-based. Always keeping in mind mass reduction, but not destroying the epithelium, the mucosa, the covering of the vocal folds. Which other options do we have? Another option is that we can inject medication into the lesion. We call it intralesional injections of medication. And one of the medications that is used since more than 2 decades is cidofovir. Cidofovir is an antiviral agent that was not made for treating HPV, which means human papilloma virus, but it was made for other viruses. But still it was used for the papilloma, and if it's not in the indication spectrum, we call it off-label, which means it was not made for that, but still it can help. And there were many studies out that showed that it is a helpful agent that can be injected intralesional, always when the patients show up again for their treatment. And keep in mind that you have to always talk to your patient about the disadvantages and the advantages of such an injection. There's also another agent on the market. It's called bevacizumab, and the brand is called Avastin, and whoever looks on the internet for that frequently sees, okay, Avastin injections is also helpful. So what is that? That is not an antiviral agent, but it's an agent that inhibits the growth of small little vessels, feeding vessels that are inside of the papilloma. So if you kill the vessels, then no papilloma grow. That's simplified what it's meant to do. That means that this bevacizumab is injected also into the lesion, intralesional, while you do the operation. And also this injection can be done office-based, transnasal, or even in general anesthesia. So now we have the debulking, we have as options cidofovir, we have the bevacizumab, and then there's a fourth option. The fourth option is a so-called therapeutic vaccine. Therapeutic vaccine, it sounds a little bit contradictory because vaccination is done before you get an infection. So what is therapeutic vaccination? Even if somebody is infected, we still give the vaccination, hoping that the immune system is enhanced and will help to suppress the regrowth, the recurrence of the papilloma. And it was shown in a couple of studies that it seems to help significantly in some cases, not in all cases. There are also other medications that can be found on the internet with, let's say, indole 3-carbinol or other food additives or even medication that might help. And I think we still need to look for further studies to find, let's say, the ideal therapeutic agent or strategy to treat patients. By now, it is kind of standard of care that debulking belongs to that, even if you do it with this or that kind of laser. It is facilitated in the office when we do it transnasal with a flexible endoscope, and it can be added with off-label medication. The vaccination is off-label, and the bevacizumab and the cidofovir, and probably other helpful agents that can be applied. You can find more information about the treatment and the diagnosis of papilloma right in the description down here, where you can find all the links.